Started. So, again, if you don't mind making your way towards the front. First and foremost, I just want to thank each of you for taking the time out of your day. I'm sure you all have just gotten off work, so thank you so much for being here to have this necessary and very crucial conversation. So, my name is Sheena Freeman. I am NACI Memphis chapter president. As she's coming up, I want to thank Med Hall, who we are partnering with this evening, and they'll talk a little bit more about their organization before we start. So thank you again. And we are live streaming. If you all want to share with your contacts, we're streaming on YouTube and Facebook under the First Baptist Church Broad streaming devices. Okay.
Thank you, Sheena. Good evening, audience. My dear longtime friend Renee Frazier is sitting in the audience, and I would be remiss if I didn't take a moment just to say, if you're in NACI, you are in the right place for minority healthcare executives and those who are committed to making a difference in the work that we do to care for so many across this country. As Sheena stated, I am chair of the Tennessee Hospital Association's Council on Inclusion and Health Equity. I have sat on that council for 14 years, and now is the time. For those of you who've been in the field for some time, and certainly now, you know, we've talked about health equity, health disparities, cultural competencies for a long, long time, but we haven't really moved the needle like we should have. Will we all agree with that? And so the good news and the bad news is now somebody else is telling us we've got to do it. And so I take that as a tremendous opportunity to advance the work that we all care so much about. The Center for Medicare and Medicaid Services has said, you've got to ask the questions. You have to ask the questions about the social determinants of health, which impact the quality of life of the patients you serve. Not only has the Center for Medicare and Medicaid Services said so, the Joint Commission. So for those of you who work in accredited organizations, you know that that is absolutely the stick. It is the thing that we scurry to make sure we're doing right before they walk in our doors every 3 years. So now is the opportunity. that we've waited many, many, many decades for, and that is to really affect change in the quality of care that we provide. And as I say to my colleagues at Regional One Health, we don't need to do this because it is a requirement. We don't need to just check the box so the Joint Commission won't come back in 90 days. We have to do this because it is the right thing to do. And for those of us who brag about and think about and talk about all the great quality scores, whether that's your infection rate, your length of stay, your patient satisfaction, when you start to peel back the layers and you understand your patient population, I can guarantee you that those good quality scores will only get better, because we know that we show up differently depending on where you're from, depending on the language that you speak, depending on your health literacy. And in Memphis, we can all agree that we have some challenging economic situations. And so now is the time that we can all get together and do this work. And so I'll just share with you, when we talk about what CMS is now requiring, is that every hospital, again, it's a step, but a very good first step, because too many people come back to the hospital, right, because we didn't understand all their needs. And we're not responsible for caring for all their needs, but we need to understand and position ourselves to help connect them to something that makes them better, to improve their quality of life. And so this first year, which starting in 2024, CMS will expect every hospital to attest that they are screening persons. They now call it social drivers, so we'll change the words, but social drivers, social determinants, being able to meet people where they are, cultural competencies, bad outcomes for Black folks, for folks who don't speak good English or who can't read. You call it whatever you want to. CMS has said you must now attest to a couple of things. That is that equity of care is a part of your strategic planning process. You want to build new buildings, you want to start new services. How are you going to incorporate changing the outcomes of the persons you've chosen to serve? Improve data collection. We need to know who our patients are in order to help facilitate change in their quality of life. Effective data analysis, so it's not just data to collect and analysis by paralysis, but do you understand your data? Are you using that data with your community partners to affect change? I'm going to say it all the time, in the quality of life of those you've held yourself out to serve. Quality improvement and leadership engagement. So this isn't just for those of us who care about social determinants of health, who care about vulnerable populations not having good access, but it is an expectation of the Centers for Medicare and Medicaid Services that this starts from the top, from your boardroom, your senior leadership, your practice managers if you're in multi-group practices, but really focusing in on how are we caring for the persons that we serve. Because I believe that if we are truly going to bend the cost curve in healthcare, we have to address quality. We know that there's no more money out there. Nobody's paying more. It's hard to find people, and it's not just now. The workforce is contracted. And so when I have good quality scores, I need to take the time and pull back the levers and see, what does quality look like for my limited English-speaking patients? What does quality look like for those who can't read? What does quality look like for other populations in my community that I've chosen to serve? So I say, and I'm not a big policy, rule-following kind of person, but I obey the law. Kudos to you, Center for Medicare and Medicaid Services. Kudos to you, Joint Commission, for opening our eyes wide open and making us do the work. But I say to those of you in the audience, make sure your organization is not just doing it to check the box. We're doing it to improve the lives of the persons we serve. And the truth be told, we have to bend the cost curve in healthcare. For those of you who follow policymakers, we talk a lot about reducing entitlement spending. Well, we've got to care better for folks in order to do that, to make sure they're getting the right care at the right time, in the right setting, and that they can have more productive lives. I will close and say, I know everybody in this room is interested, but there's so many resources out there to help you understand more about health equity. The American Hospital Association has published a health equity roadmap. It is available on their website. So I encourage you to go out and do a little self-study and to ask your organizations, talk to the folks in your quality department, what are we doing to improve the life and the well-being of the persons that we've chosen to serve? And are we positioning ourselves to meet them where they are? Because that's where change happens. So thank you so very much for being here. And remember, NACI is the place to be.
Thank you for that opening, Ms. Towns. My name is Nathalie Occean. I serve as the Chief Operating Officer for MedHall, and I'm super glad that we got the opportunity to sponsor this event with NACI. So I'll talk a little bit about what we do at MedHall, which will transition nicely into the panel conversation for today. So MedHall was founded in 2017, both from a personal and professional. Is that better? MedHall was founded in 2017, both from a personal and professional viewpoint capacity from our founder, Erica, who's with us today. So understanding the challenges that are faced in caring for a loved one, especially someone who needs to be transported to and from different appointments, but also from our experience working in various health systems and various healthcare organizations and seeing the implications both clinically but also financially on patients and also on organizations when patients are not able to get to their appointments in the right time for the care that they need. We were, like I said, founded in 2017, and we were established as a certified B Corporation in 2021, which essentially just means that because we are a for-profit organization, we also have the underlying foundation that we're focused on social impact. And so we've gone through a rigorous process and assessment to ensure that we are meeting those standards and criteria of being focused on social impact metrics. Over 5 million people to date miss or delay care because of lack of reliable transportation. And as you can imagine, the costs that are associated with that, as well as the health implications that arise from that, are really astounding. And as you can imagine, when we're speaking about health equity and health disparities, those that are disproportionately impacted are usually those in minority or underserved communities, those that are in rural populations, those that are in low-income communities, and the list goes on and on. MedHall is headquartered here in Memphis, Tennessee, and we're really proud of the work that we've been able to do locally, but we also have a presence across the Southeast and even expanding further across the country as well. We are in about 7 or 8 states currently active in providing transportation services to patients and organizations in the Southeast and also in an outlying state, but also recognizing that there's opportunity even outside of that is intentional scope. Transportation is not a localized issue, but our intention and our purpose in focusing on the Southeast and in focusing on Memphis is because of the unique mobility and transportation infrastructure needs, because of the prevalence of chronic disease management that exists in the area. These are all very compounding factors that implicate or that add on to some of the challenges that patients are facing that may be different from other areas across the country. To date, we've done over 12,000 rides since our start in 2017, which is amazing, and we continue to grow and expand. We've gotten backing and support by a number of wonderful investors over the past couple years. We've raised over $2.5 million to date with some really great organizations like Blue Cross and Blue Shield in Massachusetts, Cities Impact Fund, organizations like Morgan Stanley, and the list goes on. One of the reasons that we're actually here co-sponsoring this event this evening with NACI is we were also awarded through HHS's Racial Equity and Postpartum Challenge, the phase 1 of that challenge, some funding for being recognized as an organization who's improving equity in the spaces for Black and African American, as well as American, Indian, and Alaskan Native women in the country. And so through our transportation program and the services that we offer, we've been able to impact those that are seeking postpartum or even prenatal care, but specifically for this grant, postpartum care, where transportation was previously a barrier. Alrighty, so now that we've gotten that out of the way, we will transition to the most important people that are in the room here, and we'll start with our panel discussion. And I'm gonna sit down to make it a little bit more conversational. So we'll start off by having our panel members introduce themselves, and we'll start with you, Dr. Mays, if you don't mind.
Can you hear me? Yes. Okay. I'm Dr. Owita Mays, and I'm an internal medicine physician here in the city of Memphis in Collierville. I have been practicing at BMG, Baptist Medical Group, for the past 10 years, but I've been practicing medicine for over 20 years.
I'm Dr. Dishmon. I'm an interventional cardiologist here in Memphis. Worked with Methodists for 14 years before moving on to open my own practice, which we just opened a month ago in the Whitehaven community, Metropolitan Cardiovascular Institute. And it's one of the very first times that I said that I'm proud of myself. So.
Good evening. I'm Dr. Claudette Shephard. I'm a pediatric adolescent gynecologist by training, but I also practice general obstetrics and gynecology at Regional One Health. I'm also the Associate Dean for Diversity and Inclusion at the College of Medicine, UT Health Science Center. I'm a Nathalie. I believe my membership is there, and this, I'm embarrassed that this is my first meeting, and I'm here on top. Glad to be here.
Hello, everyone. I am Sandra Madubuonwu, and I am Senior Director, Social Determinants of Health and Wellness for Methodist Lobuna Healthcare System. And my role spans through the entire Methodist hospitals and also affiliates, and our community health and wellness department, which has more than 250 employees just for the community health arm. And you will have the opportunity to see all the things that we are doing in our healthcare system. Thank you.
Awesome. Thank you all for your introductions. And so we'll get started with laying the foundation of what health equity is and how it's related to social determinants or social drivers of health. So if we could just get a couple of the panelists to kind of chime in and explain to the audience what your perspective is on what health equity is and what that means for social determinants or social drivers of health.
Thank you. Let's move a step back. What is health? We are talking about health equity. We're talking about social determinant of health. What is health, actually? So, for the purpose of this discussion, let's go to the basic definition that every one of us here have grown up with, which is the WHO, the World Health Organization, definition of health, which is a state of complete physical, mental, and social well-being without merely the absence of illness and infirmity. Sometimes I look at that definition. It's 75 years ago that definition was developed. 75 years. Still, we haven't gotten it together. If all the way back then that they know that we needed these three components: physical, mental, social. The physical aspect of it, we are trying because we know when to go to the hospital. But still, we are reactionary. We go to the hospital when we're sick. We are not focusing on preventive medicine. The mental aspect, mental health aspect of it. Remember, mental health doesn't necessarily mean the absence of mental illness. It's a complete state. We are just getting to the space of us being comfortable talking about mental health. And in our community, it's not even something that we own up to and talk about. Then the social aspect of it, that was defined many years ago. We just decided, as if we just discovered, that the social piece is very important. But when you leave any aspect of this, we do not have a complete state of health. So the question was, how does both of them relate to one another? The definition of health equity is a state where every one of us have the chance, the opportunity to live just as healthy as possible. Fair and just state is not even too much to ask for. So, do we really have that? And social determinants of health are those conditions in our environment where we were born, where we age, where we live, learn, grow, worship, that impacts our quality of life. And those things are things like housing, transportation, access to health care. All of them impacts our quality of life. And if we don't have a good housing, so the health equity piece of it is impacted. If we don't have transportation, you already mentioned, how do we get to our appointments? So there is a connection. You can't talk about health equity without discussing social determinants of health. Both of them work in tandem. And for us as a community to take care of the health of our population, we need to address both.
Thank you so much for laying the groundwork, so I don't have to give definitions. But as an obstetrician gynecologist, many of us go into that field because of the opportunity to participate in bringing life. And that is what I feel is a right of every woman, the ability to procreate and to produce life. It's important for our society. And so when I look at the concept of health equity, making sure that that happens and the end result is a healthy life that is produced. So health equity from that perspective is being able to participate in what is perceived as a natural process. Physicians are there just to kind of support, but the parts are there, the processes are there, and we need to be able to support that for all women.
I would define it as equal health care for every race, every gender, everyone. And that's not what we have. In certain areas of the community, you might have substandard health care, mainly because there are no providers in that area, or problems with patients communicating with possible Caucasian doctors or their African American doctors because of lack of literacy or other issues. And I just want to add that it is impossible for the patient to achieve the best physical health if they're struggling with mental illness. I want to agree with that. That is an under-recognized problem with patients. Many times they're being given more medication when their mental illness or stressors need to be addressed. So I really believe that needs to be addressed.
And I really want to piggyback off of that. Something as fundamental as the foods that we eat can contribute to inequitable circumstances in regard to our health. If we don't have access to nutritious foods, you may have a disproportionate amount of high blood pressure, diabetes, high cholesterol, and those things can contribute to disproportionate numbers of patients with heart disease, who have congestive heart failure, who have high blood pressure that leads to kidney failure. So a lot of these things are very fundamental on one end, but the contributions to the negative impacts to our health care are pretty astounding. And one of the most astounding things that I know here in our community is that when we talk about, lifespan, the average lifespan of someone in Whitehaven is about 70 years. Can anyone take a wild guess of what the lifespan is of someone in Germantown is? It's 82 years, a 12-year difference in what's supposed to be the same community. And I think that's really unacceptable, but there are a lot of contributing factors to why that is, and it's things such as, lack of access to nutritional foods, lack of access to physicians, lack of access to education, a lack of awareness. Even things such as bulletin boards. The bulletin boards may have something about the next rap concert instead of a doctor you can go see. So things like that can totally have a negative impact on our healthcare in our community, and it's been demonstrated very well in our community here in Memphis.
Yeah, thank you all for those responses. One of the things I wanted to call out from what I heard from each one of you is that access is not limited to just getting to and from. Language could be an access issue, literacy can be an access issue, finances could be an access issue, housing can be an access issue. So it's not just about getting me to the appointment. What do I do when I get home? How do I understand this information? How do I empower myself and my family to help us understand how we can take care of ourselves? So thank you for those responses. The next question I wanted to ask, kind of thinking about Memphis specifically, and I know it's hard to kind of pick and choose or rank which one is most important or which one is most prevalent, but from each of your individual perspectives, because you all each have your own focus in your professional backgrounds, are there any factors or drivers or determinants of health that you're seeing come up more often for your patient populations?
I have the privilege of working in community health and well-being. Like I said, social determinants of health is what I do, and therefore, so what we see in our community that is the need is just what I listed: housing, food insecurity, transportation, access to care, safety. So when I speak about housing, we're not only talking about affordable housing, which we don't have, we are also talking about livable housing, because there are some of our neighbors in our population that live in the houses that is not even a livable housing, infested by roaches. There is a lead problem, and you wonder why the people that live in those houses frequent the hospital. It's because they do not have, the children have asthma, and there is a lot going on in the house that is not a safe area. Then when you talk about housing also, the houses, the weatherization is so poor that at the end of the month, the MLGW amount of money they pay is so high that they spend that much money paying for MLGW, there is no money left to pay for rent. Or they have to choose between rent, food, and paying for gas and electricity. Then they will want to use their stove to heat up the home. There is the safety issues. When we talk about transportation, actually let me stop. When you talk about transportation, we have teen care rides, which is a disaster. For example, if I have a doctor's appointment by 9 o'clock in the morning, I'll leave my house maybe 8:30, go to the doctor, finish, go to work. Our neighbors cannot do the same thing because they don't have transportation. When they schedule for the teen care ride, which takes a lot of time and run around for them to get it scheduled, once it's scheduled, let's say they have appointment, the same scenario, 9 a.m. They'll be picked up by 7 a.m. and they keep picking up everybody else along the road, and they drop them off at the doctor's office. The doctor's office takes just 45 minutes or 1 hour. After that, they sit at the doctor's office for the next 4 hours waiting for the ride to be picked up. So do you know what that means? For the whole day, for 1 hour doctor's visit, they've been sitting there for almost the whole day. Tell me why the next time, why they will want to go to the doctor, because they are losing their whole pay for the day. And then we in the medical field make fun of it and say, oh, She's a no-show again. Why is she a no-show? Did you ask? Did you know the reason? Do we have the empathy and the understanding to see why is a no-show again, and what are we doing about it?
I'll try to address it specifically for prenatal care. Background story in terms of transportation. Years ago, I had a patient who had chronic hypertension. She was about 25 weeks pregnant, and she was determined to make her appointment. It took 2 buses, MATA buses, to get to the appointment. Has anybody here ever ridden on MATA? You need the bus schedule, and you need to make sure that you have the bus, all of the schedules for all of the lines you need, and you have to pray that the connections work. So she made it on the first bus, but she missed her connection. So she was determined. So she walked. Chronic hypertension. She walked to the appointment because she wanted to make that appointment. So guess what her blood pressure was when she arrived? And I don't think you can isolate the social drivers of health. You can't, because as everything impacts our patients. When they have to choose if somebody is diabetic in pregnancy, they have to choose all of the plans that we have for them, the diet we plan for them, and we have what they have to get, what they have to purchase, the special foods, versus feeding their family. As you mentioned, missing, you may go to the internal medicine doctor once a year or every 6 months. In pregnancy, we expect about 13 visits, monthly, then every 2 weeks, then every week. And if you have to go through that each time, you may not have a job after you come back from your maternity leave. So we're seeing everything. And then the education. We're accustomed to sharing information. We provide paper. We'll hand out all of the information. Have we ever checked to see if our patients understand what we're sharing with them? I recall when my mom was sick, I stayed with her in the hospital. No one knew I was a physician. I figured I'd do, secret shopper. And physicians would come in and they'd rattle off and then they'd go. And she had a stroke, so it wasn't in my area. And so a lot of the language, I had to go and Google some of the information. So a lot of times our interaction, our communication doesn't address the educational level of our patients. And our patients love to support their physicians, so they'll just agree, and they may not ask the questions. The literacy piece comes in there. And so they may leave that encounter not really knowing what we want them to do. And we feel that we've checked off what we've provided that education. We've given them a 13-page handout that summarizes their visit, and so we've met that obligation. So 2 things. I don't think we could separate them because that is their life, and especially for us, we're not only addressing those needs for the patient, but we have 2 patients. We have the mother, and then we have the developing fetus within.
And so, yeah, I'm going to speak very briefly also to the education and awareness part of this, and I encounter this every day as well with what I do, most predominantly with the treatment of hypertension. So, for instance, with hypertension, a lot of patients kind of think they're destined to have it, especially in our community because we're black, so we think that we're just going to get hypertension eventually just by default of us being alive. But nonetheless, in treating hypertension, I think a very kind of a misunderstanding is that you can treat it with one medication. They think they can take one medication, it's going to take care of their high blood pressure, and life goes on. But what people don't know is that it takes 3.7 medications to treat people's blood pressure. So that's 3 or 4 medicines. So usually more 4 times than 3. And so when you add medications, people get discouraged. Oh, doc, my pressure's still not controlled. Then you add another one, you get even more discouraged, and it's more difficult to be compliant at that point because you're taking 3 medicines a day. Some you have to take twice a day, and again, no matter how much you try to explain this, I'm like, look, you're normal, you're average. 4 medications is not too much. That's normal. That's what people take. It's still a bit discouraging because they feel like that they're failing while you're adding medications to their regimen. And unfortunately, again, people aren't compliant, and we deal with sequelae thereof, like heart attack, stroke, heart failure, and so forth. But nonetheless, I think, again, we have a challenge in regard to education, awareness, access. There are only so many patients I can see in a day. I purposefully put my practice in the community that I did to expose myself to some of the community that require my services the most. And I think that more physicians need to do that. I think, I know the physicians on this panel have done that for themselves because I work with them since I was a baby doctor. So, but I think that there's definitely some commitment there from the physicians in the community, but we still have a ways to go.
From my standpoint, what I have seen and actually was surprised to see is a lack of connectivity in the community or patients being estranged from families. We assume that patients have the support of families if they have adult children or if they have brothers and sisters, but that's not always the case. The patient may have family, but no support in trying to help them take their medications, or simple things like needing a ride back from a colonoscopy. I've tried to schedule patients, and I'll say, we need to get your colonoscopy scheduled. Well, I don't have anyone to take me. And then I go down the whole list. Do you have a sister? Do you have a friend? Do you have a neighbor? And all the answers are no. Do you have a church member? No. So that has been surprising to me. And to Dr. Dishmon's point, basically when we're trying to make sure that these patients' blood pressures are controlled, we're trying to prevent long-term complications. And I don't know a lot of times if patients understand that. Most people think that diabetes is the only thing that can lead to end-stage renal disease, but years of uncontrolled high blood pressure without any trace of diabetes can wind you up in a dialysis chair. So it's important that patients understand the why behind why we give medications and the long-term complications.
Got it. Thank you for those responses, panel. And kind of dovetailing off of what you were just speaking about, Dr. Mays, for Dr. Dishmon and Dr. Shephard, if you all, for your respective clinical areas, can, most of the audience we know work in healthcare, but we also have some community members here. So it'd be awesome if you guys, Dr. Dishmon and Dr. Shephard, can share what does it mean for me as an individual or you as an individual if I don't have the right resources to access healthcare, if I don't have the same access or same quality of care that other folks may have? What does that mean for me down the line for my health outcomes, et cetera?
It impacts you negatively. It can lead to you having a shorter lifespan, much akin to the patients who live in the Whitehaven community compared to those who live in Germantown. So it's plain as day can lead to a very negative impact, including death, aside from other consequences, such as more difficult to deal with high blood pressure, diabetes, etc.
I mentioned that we have two patients that we're dealing with in prenatal care, and the reason why we address care throughout the months is to assess the growth, the health of the pregnancy, the baby, the mother, and without access, baby's going to come out soon. what is actually delivered may be compromised. So that healthy outcome, that crying infant, that may not be possible because there was something that needed to be addressed in the course of the care, of the prenatal care, that was not. We have intrauterine growth restriction where the baby's not growing adequately because the placenta, or what people call the afterbirth, is not doing its job, is not able to provide adequate nutrition for the growing fetus. So that can be a problem if mother has an underlying or a condition that develops in pregnancy, be it diabetes or high blood pressure. That can worsen if it's not monitored. Fortunately, we've been able to participate in different programs that allow some home monitoring, but if that access is not there, if something is not diagnosed, pregnancy is a wonderful diagnostic tool because we find out if somebody's going to be at risk later on in life for a lot of things. But if the access is not there, then we may have a resultant delivery that is a very poor outcome, as in fetal death. And many times in the position that we're in the emergency at Regional 1, we will see patients who come in to our emergency department having had no prenatal care, and oftentimes that's what we're seeing. Or there's a worsening of a condition. You know, you've heard of preeclampsia, toxemia of pregnancy, that because it was never caught early or monitored, we have emergency conditions that affect both the mother and the child. So we could have death of both in a situation like that without access.
Something else that can contribute to the death following what we were talking about is lack of cultural humility. Sometimes the healthcare personnel, be it nurses, be it physician, needs to pay a little more attention. And sometimes because of the burden that is placed on them to see this number of patients or so, sometimes there is that area of not paying too much attention to our clients, our patients. We have one of our clients that was pregnant, had a baby, and was losing weight consistently. Our nurses, one of the nurses keeps saying, go back to the healthcare provider. Every time she goes to the healthcare provider, she's sent back, and she's told she's depressed instead of a full assessment, until the nurse, the home visitation nurse, said, no, I'm going with you today. And she did. Eventually, to cut the whole long story short, she had tuberculosis. And it was in a phase that she has already infected a lot of people. And remember, this nurse has been exposed. But if the healthcare worker had taken time to listen to all the complaint, that would have been a way to solve the problem. So cultural humility is important. Myself, personally, I have 4 children, never with any complications. The last one, after having the last baby, I developed postpartum preeclampsia. It's a very rare condition. The preeclampsia, when you are pregnant, is easier to take care of, like you will know. I'm a registered nurse and I've done OB all my life. I'm also a midwife. So when that developed, in my case, after my many decades of practicing, I've never seen one. So when I got home and called my physician, after my doctor, my OBGYN, after 2 days of having this severe headache, I called her and she said, Sandra, please go and take some Tylenol and sleep. You do too much. So I think you need some rest. It continued. The next day, I called. No, Sandra, you do not have postpartum preeclampsia. You're diagnosing yourself just like we all do because we're in medical. Please go rest. So I kept doing this. The next day, I couldn't sleep, I couldn't do anything. So I told my husband, I am going to the hospital right now. And we did. When I got to the emergency room in the hospital where I delivered, my blood pressure was 200 and the diastolic, the lower bottom, is 160. I could have been dead. I just don't know how I was alive. At that point in time, I could have stroked out. Anything could have happened. Now everybody was running helter-skelter, and I was admitted in the ICU where I stayed for 4 days. But if she had taken time to listen and say, let's check this out, instead of saying, I've been practicing for 26 years. I have not had a case. Sandra, go and rest. Go and do this. Even with my level of knowledge, even with my level of delivering babies, even with my level of knowing this field very well, I was still not listened to. So I think listening is a skill that our healthcare providers, nurses, doctors, everyone need to learn, because most of the deaths, if you listen to the recent report on maternal mortality, most of the death, 82% is preventable. So if we listen a little bit more and do a little bit more, we may prevent people from dying. And also, people it's not even the socioeconomic class. If some people like Serena Williams got into trouble, she has all the money, but nobody listened to her. So if we can listen to people, every patient, every person is the expert of their life. So I can tell you more about your life than you can tell me. So if we can listen a little bit more, we will be able to prevent a lot of mistakes, a lot of errors, and save a lot of life.
May I just say one thing? Not only listen, but we need to know which questions to ask, because our patients don't know. They can't tell us. They don't know what to tell us. They don't know to mention, yes, I had the worst headache of my life. They don't know that that's important. But we have to know that and ask those questions, or else we'll never get the answers.
Yes, thank you for that. And that's going to lead into my next question. But before I go into that, Sheena, how are we doing on time? We're good? Okay. So Dr. Mays, you mentioned a little while ago that you had a situation where we were scheduling a follow-up appointment and the patient mentioned that they don't have transportation. For you and also for the rest of the panelists, how do you establish that level of trust where patients can share that information with you? Or what are some things that you've seen within your organizations where patients know they can go to this resource to say, hey, this is what I'm missing in order for me to get the health care that I need?
So one of the things, I'm going to come back to that, okay? One of the things that she mentioned was listening to the patient. And many times, if a patient has high anxiety, they can't communicate well what their needs are, because they may be kind of all over the place trying to give you the history. For instance, if a patient comes in with abdominal pain, I see chief complaint abdominal pain, and I go in and I let them talk for about 3 minutes, and they have yet to mention that abdominal pain. I need my ears cleaned out. My little toe is numb. They mentioned I went to the dentist and he gave me an antibiotic because I have an abscess, and I have to bring them back in and say, okay, let's start again. You came in for abdominal pain. So the issues with mental illness, anxiety, and depression can even limit the patient's ability to communicate their needs to their physician. So it's very important that that be addressed. And one of the things that we have at Baptist, you can go on Baptist Online, I think it's baptistonline.org, where you can look up community services, where the patient can see what Baptist offers within the community to help them with transportation or with social determinants of health. Also, Baptist participates in a lot of health fairs during the year to try to help patients with chronic disease and mental illness. They actually participated in a project last year. I think it was called Just Heal Bro, where they address mental health in African American men.
I'm sorry, what was the question?
Yeah, so the question was, how do you establish a space of trust for patients to be able to open up and let you know when they need things in relation to access and care, or what resources do you find within your organization that patients can go to express that they have these needs?
In my experience, patients can, within the first few minutes, know if they can trust you. And that's very important. Listening, hearing them address things in their own words. Of course, we have to direct them to make sure that we get to what we need to get to. But facial expression, body language, all of those are important in establishing rapport with the patient. Patients will not share very personal information that's important to their care if they don't trust you. We have trainees in our program, residents and students, and many times they'll go and speak with the patient and come out, and then I'll follow, and within the first minute, totally different history. Either because the patient's like, well, those aren't really my doctors, or over the years I've learned to approach the patient, giving them the eye contact, making sure they know that they're the most important person in the room. I was at a session during lunch today, and they mentioned that the average encounter, the provider interrupts the patient like after the first 11 seconds or so of them speaking. So respecting them and how that respect looks ends up being important, because otherwise they're not going to share, they're not going to adhere to treatment if that relationship is not established. And I mentioned earlier that I'm a pediatric adolescent gynecologist by training, so I deal with the little ones. And I think that has helped me in interacting with adults, because we have to be creative, you have to listen, you have to adjust to everybody in the room, the parent, the patient, their sibling, and be able to appreciate and read the room. And that's how I've done it over the years. I've been doing this for like 32 years. Started when I was little, sorry. And I think over the years I've just developed a sense of that, and that has helped me a lot. And in terms of resources, for our prenatal care, we have, of course, a lot of resources in the office, but we've started an entity called Group Prenatal Care, which allows for a lot of education as our patients are in basically cohorts. So we have several being seen in groups, and they're learning, and that relationship also is supportive, as well as they're getting the regular vital checks and all of those things. But that supportive nature has been shown to improve adherence to appointments, as well as better outcomes. So that's one of the things that we've been doing at Regional 1.
For Methodist Lobona Healthcare, as I said earlier on, we have a division, Methodist Lobona Community Outreach, with more than 250 employees that addresses the needs of our community. This is done through many programs and initiatives. So to build trust, when we build these programs, we go to people's home to see them. So we do home visitation. We have nurses that go to the homes and enroll clients, we call them clients, when they are pregnant, earlier on in the first trimester, and stay with them until the baby turns 2. In that program, we do assessment, make sure they go to their doctor's offices. At the 5th visit, we do what we call, how is it going? We're building bond. We want to make sure we are treating you the way you want to be treated. Motivational interviewing skills. We have another program called Healthy Family America. That one is done by paraprofessionals. When we enroll you into the program, we see you from pregnancy or after the baby is born, when the baby is 3 months, until the baby turns 5 years. There is this building of relationship is an evidence-based program, which means it has been tried and true. And we have other programs that are located in the clinics, which our pediatric clinics, where we assess the babies and the mom about social determinants of health and adverse childhood experiences. If they've encountered any adverse childhood experiences, which are the traumas people go through before the age of 18, if they encounter that, we refer them to mental health professionals. Sometimes what they encounter is, how do we take care of our toddler that are having issues? If you know, the study have shown that little kids are actually taken out of school, toddlers, for truancy and for not behaving very well. So in such situations, if we have them, they come to the clinic and they complain about that, we partner them with a counselor to help them. We have in our hospitals, this is one of the programs that actually warms my heart. It's called Social Determinants of Health Initiative. When people are admitted in our hospital, Methodist North, South, all our hospitals, the only place we haven't expanded to is Germantown Hospital, and that is coming. We do an assessment on those patients on social determinants of health. We use the CMS tool, so we check for housing, for transportation, access to care, and all that. And when we get those information, we build the relationship with them while they are still in the hospital. Once they leave the hospital, we connect with them and make sure we're helping them to find housing. If food is the issue, we refer them. We have huge partnerships with a lot of people. The food bank, so we refer them to food bank. We have a lot of resources in our community. We have Green and Healthy Home Initiatives, which is a national program. We partner our patients, so when they leave the hospital, if they have housing issues, our outreach coordinator will refer them to Green and Healthy Home Initiative, who will do assessment and actually do home modification if there is a need to do that free of charge. We have a lot of plethora of programs that addresses health equity. For example, in our LEAD program, we call it Labona Early Intervention. We have people that work in daycare centers and take care of kids with health challenges like G-tubes and all those tubes. So they take care of them in those healthcare centers so the mothers can go to work. So that addresses health equity, that addresses social determinants of health. We also have partnership with Agape, have partnership with MIFA. So the works, when we talk about housing, we have people we refer to housing, we have people for food. So we have all these partnerships in our organization. We have the Congregational Health Network, which is Methodist Labona Healthcare, have partnership with more than 500 churches. About 300 of them are very active. We have liaisons in those churches. So we present topics like hypertension, what do we do with it? We present it and the churches log in and they are able to listen to us. Not only that, we do what we call community health needs assessment. It's not enough for us to get up and say, this is what we need to offer. We do this a survey. It comes up every 3 years. Even though it's an IRS requirement, we take pride in doing it to make sure we know what do we want to do in our community. For this year, we just completed one. There are a plethora of issues in our community, but the two that bubble to the top that we want to focus on is, well, heart diseases and cancer. It doesn't mean that we're not going to take care of all the other ones that we also identify, like mental health, maternal mortality. We are addressing all of it. But the community told us, or from what we saw, that these are the two killers in our community, especially African American community. The studies have shown that for every 3 people, 3 people die from cardiac conditions. 3 African American die from cardiac diseases compared to 1 person from our other counterparts, white population. So we are paying close attention to what the community have told us to take care of. When it comes to social determinants of health, they talk about poverty. So those are all the things. We have so many programs in Methodist Labona Healthcare that addresses the needs of our patients and clients inside and outside the walls of the hospital.
Wonderful. Thank you all for your responses so far on the panel. I do have one more question I want to ask, but I first want to open it up to the audience. If anyone here has any questions that they'd like to ask of our panelists, feel free to come on up and we'll give you a mic. Don't be shy. Yes. Can you hear me? Yes. Does he still need this? So that way the folks on the live stream can also hear your question.
Thank you guys for all the questions. I was just curious, how do you place the importance of spiritual and emotional health? I heard a lot about mental health and physical health, but what role do you think emotional health and spiritual health play in influencing the rest of the other health that you spoke about?
I'm sorry, for some reason the echo, it didn't come out, the question didn't come out.
So you mentioned partnership with churches, and you guys spoke a lot about mental health and how sometimes patients who are going through mental health are not able to explain their problems. I'm just curious about other parts of health, maybe emotional health. Are they interlinked, or spiritual health? How do those two influence the other components of health? Is that things that we also have to be mindful of when we talk about social determinants of health?
I think, I was trained in whole person care. So similar to not being able to separate the social drivers of health, a person is the sum total of their experiences. So they bring to the table not just their physical, they bring their emotional, the mental, their experiences in life. And we know for a fact that any one of those can influence the physical, which we often dwell on. And so, number one, I think that's a given that it does affect their experience and the outcomes. And not addressing that in our review systems, we lose a piece of information. One example for me is if somebody has been habitually abused in their home, we may see them exhibiting, let's see, sexual abuse in their home, we may see them exhibiting sexual behavior early. So if you have a young adolescent who people label as being loose, I train my residents, the first question, you need to know what that experience, where that comes from, what's going on in their life, because that frames what they bring to the table, that frames their behavior. So I don't think you can separate that from the person, and we do need to address all of that because it does have a major impact.
You can learn a lot if you just listen to the patient for 3 minutes. While they talk, I listen and I read between the lines. And if I can't connect the dots and they appear to be anxious or having issues, then I'll address it. I have to be careful sometimes because patients sometimes don't think I don't believe what they're telling me if I approach anxiety or depression and I'm just meeting them. But I will say 98% of the time, I'm correct. The issue is African Americans don't like the idea of you saying that they have anxiety or they have depression. You're telling me I'm crazy, there's something wrong with me. So I try to approach it from a standpoint of, are you under any stress? And that seems to break the ice, and they can tell me what's going on. But if they have a lot of job-related stress, family-related stress, or other social determinants of health, it directly impacts their high blood pressure. We may be adding 1, 2, 3, 4 blood pressure medications, but until you address that anxiety, it affects their blood pressure. It affects their diabetes. Their diabetes may be out of control mainly because they are constantly under some unrelenting stress that has not been addressed. So yes, it directly impacts their health. I also tend to sometimes minister to patients. Again, there's a lack of connectivity a lot of times with the spiritual, and I have to say, well, my Christian belief is about to come out. So, and I'll say, are you a Christian? And sometimes they'll tell me no. So do you mind if I share? And they'll let me go on. So you do have to address the whole person to get them the help that they need. And again, over the past, I'll say 5 to 10 years, we've been hearing a lot about adverse childhood events, things that happen to people in childhood that they're still struggling with today. And there have been a lot of older men and women who, again, have a lot of chronic diseases. And, you know, I can remember one case where I had this old lady and I was trying my best to get her blood pressure under control. And this went on, and every time she'd come in, I'd ask her about anxiety or depression, and she'd deny, you know, it's just the normal stress of life. A lot of things that African Americans feel is normal is not. There is such a thing as pathological stress and normal stress. You can love your job and you can love what you do, but you still have certain stressors that you deal with every day. Pathological stress keeps me awake at night. Pathological stress, I can't eat, I can't sleep, gives me anxiety, depression, things like that. So that's when it needs to be addressed, and it's directly impacting your health.
So with your question, remember mental health that we've been talking about is not merely the absence of mental illness. Emotional health is part of it. And also that includes how do you deal with circumstances? What about resilience? How do you bounce back? So those are all the things that are included in the discussion for mental health. Another area that I want to touch on what we do as a system, Methodist Lobona Healthcare is, which I think other areas do it, is your associates, which are our staff, they are also our community. You need to take care of the people that work for you so that they can be able to take care of other people. It's a parallel process. When you hold the person that reports to you, they hold the other person, and then they hold the patients. If you don't take care of the people that report to you, how do you expect them to go into the community and do a good job? In our system, we have a plethora of things that the system provides for associates to address mental wellness. We have issues, we have things like mindfulness, we have things like exercise, Zumba, anything you can think of is in our system for you to access and live as healthy as you can. We also address health equity for our clients or our associate. Every place may have tuition reimbursement. Methodist Labona Healthcare have tuition reimbursement, but we went, and that is a quality because anybody can assess that. We've gone a little bit towards equity by making sure that that tuition and reimbursement, we have another partnership with U of M where our associate can go to school in their own time. They don't have to go to nursing or anything. They can go to trade school. So, and they can go in the night, in the afternoon, any time that is convenient for them. So that's addressing equity that is gonna make them have money in their pocket down the road. So mental wellness is very huge. We have one-on-one discussions with our staff. You sit with them and know what is going on with them so that they can perform their work very well. So that is all the things we have in our system to make sure we're taking care of our community in the system and our community outside the system.
Thank you all for that. Are there any additional questions from the audience? Yes.
I know we're running short on time, so I'll be very, very direct. One of the things, because I've been looking at social determinants of health for about over a year and going through some committees, one of the things that came up that was alarming was the care for young females between 13 and 16 and getting them on a regular pattern of care. And I'll go with this. It was determined, or it seemed to be found, and I'd like to know what your experience is. They had the juggling of doctors between one visit to another visit. It never got consistent. But when somebody found a problem, they were somewhat hesitant because another doctor had seen them. Have you run into situations to where you've run into this, because there is a such thing as a professional courtesy, but it takes more time and education for a young adult? I was just curious because those numbers came out in Memphis to be a little bit more than average.
The age was 13 to 16, and they're juggling between providers.
I think what he's saying is you go to a clinic and there are several providers.
Okay.
And then they see one this day, one the next time.
Oh, so they don't know who their doctor is. So the question is,
Have you personally had to be like in a conundrum where you've seen them go through a series of treatments with various doctors to find something that
okay.
was totally irregular or should have been discovered, and now you're like, do I report this? Have you found that?
So that because of the lack of continuity, if it resulted in a delay of a diagnosis, now not necessarily in that age group. In our system, I'm the only one that really sees those under 17 for GYN care. So we have the continuity there. But I think in some, I guess that would be more of somebody who does general peds in terms of weighing in. But many times they have continuity based on who the overall staff person is. If you're in a large practice, like we have several large groups, children's clinics throughout the city, and sometimes when I see those patients, I'll ask them, who's your doctor? And they're like, well, there are several. I don't know that it has, I don't have information to say that it has significantly delayed a diagnosis and resulted in a poor outcome. I just don't have that information.
I don't do pediatrics, but I do believe that you get better care when you have one physician who knows you, who gets to know you, and over the years, they can remember, oh yeah, he's got multinodular goiter, he's got this or she's got that. So they know you as a person, they know your history, and I do believe you get better continuity of care when you have one provider.
Not strictly what you asked, but I know there is a problem with the disconnection with care all the time in every area, and our system is moving into some data system called EPIC, because we've realized that I don't understand why, if you are in a Methodist care system, if you go to an ear doctor, you give all the information. You go to the eye doctor, you start all over again to give the information. You go to your OBGYN, you start all up. It's the same system. So we are moving into this EPIC that will help us, once we have your information in one place, whichever doctor you see in our system is able to assess the information and not ask you the same question over and over and over again. So that's where we're going to. And I can see, yes, from what has been going on, it's possible to miss something. But this is the area that our system is trying to see if we can navigate, take off the burden of patient giving information all the time that we should have known before even they get there.
Well, thank you very much to those questions from the audience, as well as all of you all who are here this evening, and most importantly to our panelists. Oh, one more thought? Go ahead.
Just a thought. I think it's very important, and one of the things that we try to do as providers is to empower our patients to get the care that they need. I mentioned earlier that sometimes patients, they're almost apologetic. I'm sorry to bother you, but this, that, the other. And I share with them that, you're paying for this. You need to get the answers that you came to get, and don't let us off until we deliver on the promise that we made to you. And I think that might help. If we empower our patients, it may help with some of the inequities that we're seeing, and because they need to know that this is for them, and unless we do that, they may never be able to get beyond where we are now. This comment.
Absolutely. Thank you for that closing note. Well, thank you again to you all, and thank you to the panelists for being here this evening and sharing your insights, your experience, and your various perspectives, given your various clinical backgrounds. Let's give a round of applause for those panelists. All righty. Well, I'm going to pass it off to Sheena to close us out. And also, I forgot to mention in the beginning of my presentation about MedHall, today is actually our anniversary. So 2017 to this day, we've been around for 6 years. So super excited about that.
Thank you all again so much, Nathalie, all of our panelists. You all have been so amazing. When I asked, you all said yes. So I thank you so much for that. And for all of you for taking time out of your night to come here and talk about and listen to this crucial conversation. Thank you. Wherever area you work in, I hope you're able to take something back to empower your patients, to empower the community, your loved ones, because it's all about getting the healthcare that we need. So thank you again. If Ms. Patty will go to the last slide, I did mention that NACI is an association based on membership. I said that. So before we go there, I would like you all to scan this QR code, because as NACI Memphis does programming, we want to know what's working well. And we use the feedback you all provide to tell us what's going well and then things we need to work on. We try to be intentional about programming based on developing leaders, healthcare leaders, but also programming based on things like this, where we're talking about improving the quality of care of our community. So share your feedback with us. And then the next slide will go into, if you're interested in becoming a member, please scan that QR code. If you have questions at the end, you can, if our executive board members will raise their hands, and any of them will be able to help you if you're interested in learning more about NACI and how to become a member. So again, thank you all for being here. Thank you, Med Hall, for the dynamic partnership. Thank you, First Baptist Broad, for hosting us this evening. And thank you all, and have a great night. Thank you.